our first presentation. It's going to be given no other by Dr. Diana Martinez. So Diana has not been in Canada long, but she quickly assimilated herself, asserted herself, and has really started doing a lot of research, some of which you're going to see here, but there's just a lot more going on. She actually completed her medical school in Colombia before moving to Canada. And she's been working on our research team at Institute for Better Health and at PRISM, and again, has really been doing a lot of great research work. She is, for instance, leading a lot of our, we're going to talk a little bit tomorrow about wait times, and we soon realized with the wait times that the biggest concern sometimes is the ones that are not even on the wait list, and we call that wait zero. And she's been doing a lot of kind of qualitative work related to trying to find these people, who they are, what can we do to better help them to get them onto one of our wait lists. So Diana, go ahead with the findings from the environmental scan.
Okay, thank you so much for the introduction. And I'm really excited to be here and happy that this meeting is coming together. So, well, I'm going to present the findings on our environmental scan on appropriateness and prioritization of cataract surgery. I don't have any financial disclosures. And okay, so moving into the background, as we all know, cataracts continue to be the leading cause of blindness worldwide. And it causes high impact in functionality, quality of life, and could even threaten patient safety. Currently, there is a lack of a standardized prioritization or appropriate tool that will help us manage wait lists in a standardized way. The available criteria are either out of date, unreliable, or have not seen widespread application in the clinical setting. So the purpose of this environmental scan is to ensure that our collective knowledge is up to date and start what's the current state of the situation right now and identify key experts in this field to bring together in this meeting. So moving into the methods that we use for this environmental scan, we use a 5-stage methodology. So the first stage, we define which were our questions, our research questions. What are we going to be looking for? So first of all, we were looking for further research on cataract surgery, appropriateness and prioritization. We're looking for any new tools that were developed and which ones include patient-reported outcomes. We also were looking for which of these tools have been used in a clinical setting or widely in health systems. And we wanted to look into the impact of sex and gender on other dimensions of equity. Moving into the second stage, we identify the relevant studies. So we used PubMed for this. We use keywords, so cataract surgery and prioritization, waiting list, indication, appropriateness, patient-reported outcomes, and equity and gender. Once we identify these first studies with this first search, we look into the keywords of these papers to find more keywords. And after that, we went by hand checking the references of each paper to maximize all the results that we were getting. And this was conducted by me and Daniel, one of students that is helping us. So we moved into selecting the studies. So we had inclusion criteria. We were looking for studies that will be focusing on prioritization and delivery of cataract surgery. It had to be published in English or that translated into English. We had exclusion criteria when we have lack of discussion on a method or a tool, there was a presence of inconclusive results that we could not get conclusions out of it. Then we move into sorting the data. So we compile a list of articles and associated papers. We extracted the information for each paper, included the title, authorship, country of origin, date, and then we use a different list to compile all the authors that were publishing on this. So we organized in this author list by ranking based on the number of associated papers or publication in each of the different topics that we were discussing. Then we move into the collating the results. So we perform mathematical analysis to assess the results and then compile the themes and trends that we found. So this is our Prisma flow chart. So in the first search, we identified 377 papers. Then after we removed duplicates and the ones that were ineligible, we got 277. Then we scanned this one for eligibility, the ones that included methods and tools, and we ended up screening in-depth abstracts of 206 papers. And after this, we went and did a second screening, and we ended up reviewing 79 papers that mentioned tools, prioritization, indications, and gender considerations. For our final analysis, went 79. So moving into our findings. So first of all, I wanted to display the training publication that we found for the different terms. So here we have, for our search, cataract surgery and prioritization. In this one, we also included tools, and we also include indications. And as we can see, the search until 2022 included a total of 97 studies. Not all of these were included in our final search because some of them didn't fail to have the criteria that we were looking for. But we can see that the higher number of publications has happened since 2020, and there is a marked increase in the interest in the past years. Nevertheless, it's not many papers out there, and I'll show you a comparison further. We can see that maybe there was an increase in 2020, and just thinking about it could be COVID-19, how it increased the backlog, and how everybody was trying to find ways of prioritize cataract surgery and help with wait list. Then we move into the trend for prioritization tools and patient-reported outcomes. So we found a total of 22 studies, the higher number of studies in 2020 and 2022. There is a growing interest here in developing tools that incorporate prompts, but there are still not many papers out there that we could consider for this. And then regarding cataract surgery and gender or equity, that's the way we did our search. We also find a trend to study a recent increase in publications since 2019, but there's definitely a need for more studies on this and to a more comprehensive study specifically. So now I wanted to here present a graph comparing the number of papers published on surgical techniques on characteristic of surgical in cataract surgery, and the ones that we found in service delivery, meaning indications and prioritization of cataract surgery. My idea was to show a graph like the blue showing the papers on surgical technique and the green showing the papers that we found on cataract delivery. I did that, but the graph fails to show the green because there are so little. So we can see that there is a huge gap in number and research interest in this topic. And we can see small here, the numbers that I shared before, but I put it here as a scale to see the difference in research interest that we found out there for these topics. Okay, so moving into the findings on each of our research questions. So these were this Venn diagram to show which were the prioritization tools that we found. So we have here the Western Canada waiting list that we are gonna talk about that further. We found the Catalog Agency for Health and Technology Assessment. We have the IRYSS Cataract Priority Scores. Those two mainly were trialed in Europe and Spain, and the New Zealand Priority Criteria Project. Regarding prompts, we have many tools that have been studied, some of them more generic in general vision complications or assessing vision difficulties of patients, and some others that were more targeted to cataract surgery. And in the middle, we have these tools that have incorporated the objective criteria and the clinical measurements and the prompts or the patient reported outcomes. So just to give a little bit of an overview of the mostly mentioned in the literature tools, we have the Western Canadian waiting list, which was a project that originated with a panel of clinicians and specialists in 1999. The tool is a set of criteria for prioritizing patients on waiting lists for cataract surgery. So the criteria incorporated factors such as visual acuity, visual function, impact on daily life. So we have best corrected visual acuity, glare, ocular mobility, extent of impairment, disability, and ability to work. The validity of this tool, it was considered by clinicians to be easy to use, and it was reflective of the expert surgical judgment. Then we move into the NICE tool. So it was originated in Sweden. It was developed by teams from 9 clinics who reached an agreement about the need for the development of a new clinical tool. They based this tool on the Canadian Cataract Priority criteria tool that we mentioned before. So NICE is a clinical tool that establishes levels of indication for cataract surgery. So there are 4 indication groups. The group with the greatest prioritization surgery was named number 1, and then with the lowest level was group number 4. So the measure that it includes is visual acuity in both eyes, perceived difficulties in day-to-day life, cataract symptoms, ability to live independently, and it also considers medical or other ophthalmologic reasons for surgery. The validity has proven to be good, to be effective. Surgery, the most impact was on patients that had in the high indication group. That's when they noticed the most different when they start using this tool. And it has been widely adopted in Sweden. There has been studies now reporting the use over like more than 6 years of implementation of this. And then moving into the PROMS tools, we have the CAT-QUEST questionnaire, which was written in Sweden. It is a Rush scale 9-item questionnaire that measures activity limitations in daily life due to poor vision because of cataract. So it measures visual disability and visual-related limitations in patients' daily activities. It has been shown to be good and have good psychometric properties and is suitable for assessing patients, visual function in patients before cataract surgery, comparable with after cataract surgery. It has now been translated and culturally adapted in many, many countries, and it have kept the strong psychometric properties, including Canada. So in the map here, we can see all the countries where it have been culturally transcribed and adopted, or well, trial in studies. And then another PROMS that is highly mentioned in the literature is the one from the National Eye Institute. So this included a 25-item questionnaire that evaluates vision-related factors associated with quality of life. So it includes health, so physical and mental health, includes like vision. So we have near vision, distant vision, peripheral vision, color vision, and also role limitations in the daily life, driving, dependency in others, and in general social function. So it has proved to be valid where it has been tested the first times, but then it has mixed results. We found different studies, one showing like very like valid and could be implemented, but some mix on when it's implemented in other countries and in other cultures. So that one, the validity to further population have not been generalized, found valid. And then moving into our equity findings, we found a total of 9 papers mentioning gender and equity considerations in cataract surgery. So 8 of the papers were set in low and middle income countries. 3 were developed in developed countries, but most of these were inconclusive or underpowered to really assess equity in developed countries. And 6 of these 9 papers identified gender as an inequity in cataract surgery. So now moving into the overall findings of this search, we found regarding gender that there is an impact of appropriateness and prioritization based on gender. The possible explanations found or suggested in this study for this is difference in culture, difference in socioeconomic status, awareness of surgery, and literacy levels or rates. So women may be less aware of surgery of cataract, and that this is something that has a cure that could be treated. So in general, like less access to education in the female gender. And epidemiology studies have confirmed that there are higher prevalence of cataract in female compared to males. So that could also be related to why the backlog in this gender. And other factors identified apart from gender, we have the cost of surgery in low middle income countries. And we found a study in Australia that shows that the effective access in Australia is higher for non-Indigenous Australians than for Indigenous Australians. And there's in general barriers to access in underserved and rural communities. Some explanation will be there is a higher, they were showing this through being a higher prevalence of cataract and blindness among socially disadvantaged groups with countries. So no means of transportation, not enough money to accessing cataract surgery. So it's kind of an overview what we'll find out there on these papers. And now moving into our discussion. So we found the findings of this environmental scan highlight the lack of tools and guidelines in cataract surgery, as well as the importance of incorporating patient-reported outcomes in addition to the objective clinical measurements when we are determining appropriateness and prioritization. There are a few tools that we found that evaluate prompts in cataract surgery. The most mentioned and the one that has been valid in many populations is definitely the CATQuest questionnaire. And there are inconclusive findings on gender in accessing care, specifically in developed countries. And assessing these possible inequality issues could improve our patients' outcomes. So what are the implications of these findings is that incorporating prompts into decision-making process may aid manage wait lists and improve patient outcomes, as well as the need for future studies with sufficient power to access inequity in cataract surgery. And there is definitely a need for international collaboration to address these gaps in research. And that's where our symposium comes to work. And so how do we use these findings for our meetings? So we use these methods, and as I mentioned in the stages, to find the most prolific experts in these fields. Then we categorize targeting in specific patients. So who we're talking about prioritization, which ones more in appropriateness, and which more in prompts. And based on this and the relevant research, we send targeted invitations to our potential speakers. Thank you very much, and hope you all enjoyed this meeting.
Thank you so much, Diana. I'll open up to our panelists to see if they have any comments before we go on to Sharif's talk.
I'm just going to make a comment. I'm not sure why it didn't make the cut in your research thing, but I'll be referring to it. But there was one outcomes trial, or before all that, the first one, as far as I'm aware, was the PORT study, the Patient Outcomes Research Trial, which developed something called the VF14. And I'll talk about that in my talk coming up. But one of the things that I wanted to highlight you made a comment about the culturally adapted thing. And that was something that was very obvious from the beginning as different models were being presented, was that you just couldn't take them to another country. I remember when the VF14 was put into place and it was sort of an exciting development, then all of a sudden the predecessor of the CATQuest got developed in Sweden. I remember talking to Swedish researchers and saying, why did you develop this tool? And they said, well, a lot of your questions are so inappropriate because most people don't drive cars in Sweden, and that's a key question in the thing. And they said, we have people walking on cobblestone streets, which makes a huge difference as opposed to the kinds of environment that your patients are living in. So it really does make it difficult to come up with a single tool that's going to work worldwide.
Yeah, sorry, just one comment. Yeah, definitely. The reason I did have it in the big diagram, the VF14 and the shorter versions on VF11 and 8R. Yeah, just didn't well in detail on all of the tools that we found, but we definitely will consider that in the findings of our side. We did find it there. So, but thank you. That's such a valuable comment, and we cannot assume that everybody lives in the same conditions everywhere. So yeah, thank you.
Great, Cindy, I see your hand up.
Yes, hi, great presentation, Diana, and fantastic work. My question to you is two things. Health literacy is always a big component into what patients do and don't understand, and also just the language barrier. So I'm just wondering, when you look at these tools, do they specifically look at health literacy and what level of health literacy the patient has to have to understand what they're being asked? And secondly, are the international translations available? Because very difficult for someone who's not English speaking sometimes to really understand what may be a nuance to them in terms of what the question is asking.
Yeah, definitely. We have found that in further studies that we have been doing, how the lack of awareness on simply the not information on this topic has been a huge, if not the main barrier of accessing care. So in terms of the translation of these tools, what we find in the studies was that before they implemented this, for example, the CATQuest in patients in Japan, for example, they were first doing the translation and kind of like a consensus between different clinicians if this will make sense. And that's when they started implementing that in these focus groups, right? As in regards to like the literacy of the patients, if they really understood the tool, I'm not really familiar if there was a process on this done before, but thank you so much for that point, and I will make sure that I'll consider that when we are assessing the tool. That's very valuable. Thank you.
Great, thank you.
Great
Rob?
job, Diana. Just one comment
sorry,
maybe for the group to consider is just, you know, I think we often combine appropriateness and prioritization together. And I think it'd be an interesting discussion at some point to have about the wisdom in that, or you know, how do we look at these differently and how do we implement them differently? Because in some ways they are different questions, but yet these questions may be similar. So just put that out there as far as maybe something to consider as we think about the right tools to use in these areas.
Thank you. Yeah.
Okay, and Rob, I think you have your hand up as well.
Yes, and just a comment. Thank you, Diana. A terrific presentation. And it struck me about the paucity of the work done in this area in equity related dimensions. You know, certainly from what I could see that you did, we didn't see a lot of work around all dimensions of equity and equity deserving groups, racialized Indigenous populations, LGBTQ plus populations, and how that interfaces with both the delivery of cataract care and the outcomes that that come out of cataract care. And so I know this is going to come up at a later point in the conference, but it just seems to me that there's a significant amount of need for further exploration in this area.
Yeah, thank you so much for your comment, Dr. Reid. Yeah, definitely. We were trying actually yesterday discussing with Dr. Schlenker. We were trying to find more dimensions of equity because everything was related to gender. There was like not much on that already, but then it was the only thing mentioned. And then we found this study on indigenous versus non-indigenous populations. But in these specific groups, there's definitely a lack there to assess these. Yeah, but we will probably dive more into that in that session. But yeah.
Great, and Conrad, I see your hand up.
Yeah, look, I just want to congratulate Diana on cramming 3 decades of research into 20 minutes. I mean, that was an extraordinarily difficult task, and I really think she did a great job of it. I was really struck by the two graphs, the one of how many publications on surgical techniques, etc., and then how few publications on cataract surgery prioritization. You know, this is an issue we're grappling with all over the world, yet there's so little research. And to me, as someone who's tried to study this hard for a long time, it's almost impossible to get peer-reviewed funding for cataract surgery prioritization. As soon as you put in a grant about cataract surgery, you're certain to get a review back saying, cataract surgery is great, there's no problem. We don't need to fund this grant. Without even reading the detail of, you know, what the real issues are in access to care and inequity, which are enormous issues affecting so many people and so on and so forth. So I think that's a real mechanism that the perception is that cataract is a solved problem, that it's very difficult to fund for research.
Yeah, thank you. Just a few comments on all of that. You know, I agree with Ike's comment of appropriateness and prioritization, and I hope that that's going to be addressed actually in our next 2 sessions, where we really see that these are probably different. They're different problems with different solutions, and I hope we can really separate those and think hard. But they seem to just roll. I know they're long words, but they just seem to always go together. And I do think, well, we can decide as we listen to the presentations. And to Dr. Bellin's point, you know, and I think I'm biased too, because we're having a lot of troubles with this in glaucoma as well. You know, the EQ5D, the VF indices, they've really gained a lot of prominence. And I think they have really revolutionized patient-reported outcomes in many areas of medicine. But they do not work for cataract surgery, period. They are not sensitive for cataract surgery. They're even worse for glaucoma. But we have, you know, we have a huge RCT in glaucoma whose primary outcome was one of these, you know, indices, the EAGLE trial, for people who are familiar with it. And, you know, thankfully, people have been able to kind of stick handle around that, to use a Canadian term, But that was the primary outcome. That's what the government wanted in Europe, particularly in UK, and that's what they did. And then you're kind of left with this paper, which wasn't really set up properly. And CatQuest, when I first read CatQuest, we're going to hear about that quite a bit. I read those questions, and the comment came up, that these should be really, how you see prices. I thought, oh my goodness, that is so age dependent, that is so cultural dependent, societal dependent. Though so we kind of had CatQuest on the back burner, and we weren't going to use it that much. In fact, Trillium spent a lot of time and resources trying to create their own tool called the ECAPS tool, which is, we will touch on that. But I have to say, in looking at the research now, and we have a large systematic review on it, CatQuest has transcended time and cultures. It has been very impressive at how well it's done in a variety of countries over the years, including Canada, including beating our own tool that we tried to develop in Mississauga, Toronto region. And I encourage you guys to also, everyone, to look at those questions. And I said they're not perfect, but we do have, psychometric testing that has allowed us to show its robustness over time, mostly using rash analysis. So, as you listen to the rest of the presentations, I guess think through that. I'm not saying that we have the perfect one in CatQuest, but it has, I would say it's done fairly well. That's going to be my position. And I said, I'm here to be proven wrong. And I'm telling you, I was a doubter at the beginning.